Can I have my slides, please, Dr. Arshi Singh? Yeah, all right. So we'll be discussing the effects of ocular surface alterations in glaucoma management. The coexistence of the disease with the as a consequence of the glaucoma treatment and because it is pre-existent, the glaucoma treatment, how it causes the OSD and the management modalities. So what we know of so far is that anti-glaucoma medications cause increased pro-inflammatory cytokine secretion, interleukins, TNF factors and other interleukins as well, alters the tear film and also decreases the corneal subbasal nerve fiber layer density. So what happens because of this is, a consequence of this is all relating to your ocular surface disease. So you can see there are multiple studies that have actually studied the prevalence of OSD in glaucoma patients and also as an overlooked side effect of the glaucoma treatment and the measurement of the interleukins and the cytokines in such patients. So what we know is pre-existently also in glaucoma patients, the rate of OSD is very high. As you can see, it is around 48 to 59%. It's such as based on the symptoms. And based on the science, you can find it in around 80% of the patients, which is a significant proportion of our patients. More than 3 months of therapy is known to cause a state of subclinical inflammation. We'll talk about why this is clinically relevant to us. And the risk factors for OSD are the female gender, elderly patients, pre-existing dry eye disease, the number of medications and frequency of medications, and whether preservative is used or not. On examination, we can use the dry eye profile that we do, the TBUT and the Schirmer's test, and meibography as well. And studies have shown that all parameters have been affected in glaucoma patients. This also, in turn, relates to a poor quality of vision, quality of life, and poor patient compliance because patients would not want to put their drops. The prevalence of the OSD in glaucoma patients has been linked to the number of back-containing eye drops. The different medications can cause different side effects. For example, drug-induced dermatoconjunctivitis, as you can see over here, commonly seen with the post-prostaglandins that we use, follicular conjunctivitis. We have impairment of corneal wound healing and conjunctival wound healing, limbal stem cell deficiency, and rarely we can also have a pemphigoid-like picture. So what was seen was, perioperatively, the conjunctival inflammation was linked towards the trabeculectomy outcome. They saw that the mast cells and the HLA markers, goblet cells, had decreased and altered in numbers in patients who had preoperative conjunctival inflammation. As we said, almost 80% of the patients already had it who were on glaucoma treatment. On the corneal spectrum, we saw corneal punctate epithelial erosions. We saw patients with burning sensations, anesthesia, and as we know, the netarsadil-associated retical corneal edema has been well talked about, and tear film alterations as well, also meibography showing dropout areas. Besides the glaucoma drugs, what's the culprit is the preservative that we use. Also, as additives in surgery, we use antimetabolites, and the surgery per se causing the conjunctival elevation and thereafter causing the tear film instability and suture-related problems. Also, whenever we do an adjunctive procedure, that can also alter the corneal surface, only a conjunctival surface. So the mechanism is because of the direct toxic effect or because of interference with the tear film resurfacing or because of a predisposition to the ocular infections, which is another subset of patients that we have. You can see over here, this is a profile of patients. You can see a delin that has formed over here because of overhanging bleb. Because of the poor healing, you can see that there's a sedal positivity. Because of tight sutures over here, you can see that there is a lot of astigmatism that caused patient to have decreased vision. And as a flip side, as we said, there's a mutual relationship. Preoperative conjunctival health determines the postoperative outcome, and the number of medications that you're using and the pre-existing disease also causes the issues in glaucoma management. So it has to go hand in hand. What you do is first evaluate all patients of glaucoma for coexistent dry eye. These are the tests that we often miss in our glaucoma clinics. Please try and incorporate this into your armamentarium. Make the patient have a fluorescein staining and undergo a Schirmer's stress as well. Also, you can perform an OSDI questionnaire and tell the patients to rank according to their symptoms. Initiate the dry eye therapy early, not when the patient starts complaining about it, but when you actually see it on the signs. As I told you, 80% of our patients already have that existing disease. So try lubricants. Try using preservative-free when the patient is affording. We understand that there is economic problem and affordability issues for a lot of patients, but wherever option is there, use preservative drops. Use immunomodulating agents. cyclosporin, Restasis, 0.05% has been known to have wonderful effects, especially in patients with severe dry eye disease or severe OSD disease in glaucoma, and it has been known to increase the compliance and quality of life. Role of diffitigraph is something that's been studied now. Punctal occlusion is something that can be performed, and also low-dose steroids for patients who are non-steroid responders. In these cases, the conjunctival health improves. This is something of particular importance, especially when you're planning the patient for a surgical procedure. Also target the medication. Use a preservative-free drug. We've been talking about Purite, Sofzia for the longest time. Decrease the backload, which means switch to a combination therapy. And if there's a severe allergy, go for an AGM holiday. Stop it and switch to oral medication for a while and use steroids for the conjunctiva to heal. Now, because of the newer developments, we have novel delivery systems, we have the intracameral depots that are there, like the Durista, and under trial, we have bimatoprost ring, IDOS TR is going to come up, we have other drug-eluting punctal plugs as well, and also you can use SLT in the primary initial therapy. In our patients, we tend to see a response that fades off very early because of the higher pigmentation of the iris, but the light studies showed that it had some good effect in the initial therapy, so that can be tried initially in patients in dry eye disease. Also, as Sir just talked about, MIGS is something that we should opt for early in patients with OSD. Surgical management tips, what we would like to discuss is because of severe OSD, because of surface alteration and that subclinical inflammation, there is a lot of fibrosis in the conjunctiva. So what is important during surgery, be it a glaucoma filtering surgery, a valve, or a mixed procedure, is when you're using the conjunctiva, for example, is remobilize the scar tissue. Make sure you remove all of it, meticulously perform a dissection, use a mitomycin or an antimetabolite if needed in that area. Release the conjunctiva for advancement, for closure of your flaps by using the incisions at the fornix, which are called the relaxing incisions. If you have a very friable and thin conjunctiva, especially one that bleeds on touch, especially in valve cases, try not to use sutures and use fibrin glue instead. Use limbal-based approaches instead of using a fornix-based approach in patients where you find there's a lot of scarring at the area of the limbus. In conjunctival scarring with gaping, for example, after surgery, what you can use is initial cases, you can give them contact lenses, autologous serums, the role of systemic doxycycline is there. If that fails, go on for surgical procedures like putting a layered AMT, and if that fails, go for a conjunctival graft, which may be from the adjacent or the free conjunctiva, or a pedicle graft. So let's discuss a few cases. Now, this is a case of bilateral advanced steroid-induced glaucoma. He's a 58-year-old male on brimonidine and timolol and Dorzox with lubricants since 10 years. Recently, for IOP control, prostaglandins were added. And within 10 days, this patient comes with severe redness, watering, and pain. So I see a lot of postgraduates sitting here, which is so good. What are the possible contributions that you think are causing these signs and symptoms? Is it drug allergy, toxicity, dry eye, meibomian gland disease, or preservative toxicity? Anyone? All right. So this is because of a particular agent that you've just started. This is actually a drug allergy manifestation. So you discontinue the allergen, which in this case was bimatoprost, and probably shift them to another agent and treat coexistingly the lid and the ocular surface. All right, this is the second case. 65-year-old female, both eye advanced glaucoma, as you can see on 4 AGMs, recently has decreased vision, blurring, decrease of 2 lines vision, but the cupping is stable and the intraocular pressure is well controlled. Schirmer test is normal and moderate MGD is present. As you can see over here, you can see multiple punctate erosions. What would you think is the next step for such a patient? Would you like to change to preservative-free? Would you like to decrease the backload, give them anti-inflammatory therapy, or punctal plugs? Or all? All. That's the right part. So this is the patient on a lot of medications for a very long time, probably has drug toxicity because of the medication they've been using. So switch to combination, decrease the backload, give preservative-free, and also add the anti-inflammatory therapy. So as you said, steroids, for example, and as I said, lifitegrast has a role in such patients, and also coexistently treat the MGD. So in summary, incidence of OSD in patients is very high. This affects the adherence and the quality of life and quality of vision. So it is extremely important to treat the OSD in glaucoma patients aggressively and to start early, which improves both the surface and the IOP, and the number of drugs actually contributes. So be careful while writing that prescription. Some topical drugs are better, like the preservative-free, and special delivery systems may be looked for. Alternative options should be searched for, like laser or patients who should undergo MIGS. Thank you so much. Thank you, Kirti ma'am, for this opportunity.